Bodour Salhia, PhD from TGen organization. They have a table outside. You can learn more about the wonderful research that's being done right here in Phoenix, Arizona. We're incredibly fortunate. Dr. Salhia is originally from Egypt but grew up in Canada, has been trained both in Canada and also here in the U.S., and is doing incredibly important research on myeloma. She's part of a research collaborative. She'll tell you about that. One of the things you're going to be hearing, as you did with Dr. Kyle, is about the research that's being done. It is so exciting what's happened, as Dr. Kyle has pointed out, just in the last 10 years. But what's also important is that you can help participate in research, and they're called clinical trials, and you can speak with the doctors and go over to the different tables that are displaying today to find out more about the research and how you can participate. At any rate, I'm going to introduce Bodour. Here she is.
Well, good morning, everyone. It's a real pleasure to be here. Like Kendra was saying, I was here also. I've witnessed the growth of this conference and the whole ASMN series of educational events. And just to make a couple of comments that really were talked about quite a bit last night at the round table is that education awareness does save lives. So do not underestimate the power of these wonderful forums. So with that, I'd like to thank Dr. Kyle for an excellent talk, which actually paves the way quite nicely for mine. So he's introduced a lot of the clinical aspects of myeloma, and I'll talk to you about some of the research that we're doing in the field right now. Okay, so some of the questions a lot of you might have is, what is cancer? What is multiple myeloma? How did I get cancer and why? Why does cancer respond to a drug in one patient and not another? Why does cancer often return resistant to treatment? And what is being studied to study cancer, multiple myeloma, to better improve diagnostics, prognostics, and therapeutics? So I'm going to talk to you a little bit towards the end of the talk about some of the latest research that's being done and was presented at ASH, but I'm going to lead up to it. How do we do this? So let me start by saying that what is cancer? Cancer is basically occurs when a normal cell acquires enough changes at the DNA level to mutate it in such a way where it becomes a cancer cell. So it acquires enough changes, abnormal changes, that changes that normal cell phenotype into a cancerous cell. And as you heard a little bit already, like other cancers, multiple myeloma does go through a series of progressive, there it is. Multiple myeloma does progress, so it doesn't necessarily, it can progress from a low-grade stage to a high-grade stage. And then these are just pictures of how that happens. This is just an image of a bone lytic lesions in the skull. So conventional cytogenetics and pre-genomics have really characterized multiple myeloma at each stage. So the field has basically, with each stage of progression, has mapped some of the genetic changes that are critical to either progression or to that particular stage. So the field has been working a lot with this information, and Dr. Kyle actually talked to you about these changes and has shown how they can break up patients into high-risk and medium-risk groups. So today's method, with using that information, we really have still a trial and error method of practicing medicine. Now, it's obviously improved quite a bit, and there are dramatic changes, including in the myeloma world. But today's method, still, there's about 30 to 60% response rate to drugs, and this is in general terms. This is not just particular to myeloma. And the way of the future is to get 100% response rate. And we're working on ways on how to figure that out. How do we get 100% response rate? So what happens here, if this is just a graph, if you look at time across the bottom here, and you have disease management and symptom severity, what ends up happening is that as time happens and patients, and you move along in the disease management phase, the severity of the symptoms increases, and it reaches a point, unfortunately, where the disease management just drops, because by the time there's a drug or a new option that's available, this patient has already progressed in such a way, and we've already heard in the case for myeloma, most patients will get refractory incurable disease. And if we look at, just compare the US death rates from 1975 to 2006, looking at people under the age of 65 and people over the age of 65, and if we compare, and I used heart disease because it's a striking example, if we look at the death rates for people with heart disease who are under 65 has gone down dramatically. Now it has as well for cancers, but not as much. But if you look at the age group for over 65, the death rates really haven't improved overall, whereas for heart disease they've gone down dramatically. So there's still a long way to go in terms of improving the death rates for cancer. So saving time is crucial to the patient, the hospital, and the physician. So how do we get there? We need to identify and understand all the changes. We need to identify and understand all the changes on an individual basis. And new generation technologies are now being used to allow us to do this. So cancer research, what do we do? What do we look for? So there are many areas of cancer research. People are studying risk factors, early detection and screening, diagnosis, prognostic factors and treatment, support, dietary factors, and what happens after treatment. So these are all the areas of cancer research, and there are efforts in every one of them. At TGen, we're primarily interested in diagnostic and prognostic factors and treatment. How do we improve those aspects of cancer? So at TGen, we're interested in understanding the genetic basis of disease. So this is where we focus most of our efforts, and not just for cancer, but for many other types of diseases as well. One of the major areas of research at TGen is multiple myeloma. So if I can just go over this slide with you. So our body is made up of trillions of cells. Each cell has 46 chromosomes. You get one from each parent, so 23 from your mom and 23 from your dad. And if you were to take the DNA, which lives inside the nucleus of the cells, and stretch it out from one end to the other, it measures 2 meters long. And it's made up of letters, 4 different letters, A, T, C, and G, that are 3 billion units in length. There are approximately 30,000 genes that basically live within these 3 billion units, and this is basically just an image of what the DNA looks like. The functional unit of our DNA and of our cell is a molecule called the protein. So we want to understand the genetic basis of disease to understand the biological hallmarks of cancer, which there are several. So cancer cells have a self-sufficiency for growth. They're insensitive to growth signals, so usually a normal cell in the body might require a stimulus. Well, cancer cells can grow in absence of that stimulus, so it doesn't need the external factors. We all hear about tissue invasion and metastases. We all hear, I think we may have all heard about sustained angiogenesis. So as the cancer cells continue to divide, they need to also acquire the nutrients that sustain that growth, so they develop and generate new vessels to allow them to do that. And they evade the ability to self-destruct. So cancer cells in the body normally are able, or abnormal cells in our body in normal individuals have the ability to just self-eliminate. And in cancer cells, those cells don't eliminate, and so they continue to propagate as mutated cells in the body. So the genetic mechanisms leading to these cellular abnormalities are the following. You can get incorrect gene copy number. So as I said, you have 2 copies of every chromosome in the body. Well, you can lose a copy and you can gain copies. So you can just imagine how that could wreak havoc on cells in the body. You can have improper gene expression. So cells can be genes on in our chromosomes, and our DNA can be turned on or off irregularly. Or you can have a mutation in a gene that's very, very important to preventing cancer.